Thank you very much, Dr. Pablo, Dr. Besomi, and Dr. Pires. It's an honor to be a part of this online series, and great to be with my friend, Dr. Stubbs, and listen to his great talk, Al. Great talk as always. Thank you. And also, I have had the honor of being in Santiago, I think 3 times, and twice at Clinica Alemana. And although these are strange times and it's a strange year, it's amazing that we're all together here in Santiago virtually. And what an incredible world we live in, even in a time of crisis. So great to be with all of you. So I'm going to speak on the thought process that I go through regarding treatment of the labrum, labral repair versus reconstruction. And I hope that you might find 1 or 2 interesting pearls in this talk. So my disclosures are listed with the American Academy of Orthopedic Surgeons. One of my missions in this talk is to equip you with a tool belt or a toolbox. And the more tools that you have, the better. In treating a labral tear, we see all different permutations, all kinds of different tears and all kinds of different qualities of labra. And I think having a variety of tools in your tool belt can help you do the right thing in the specific situation you encounter. So in your toolbox, I hope to give you a few tools today from a technique standpoint. The first are 2 techniques for anatomic labral repair: the labral base refixation technique and the controlled tension anatomic technique. And then the third technique is the technique for labral reconstruction, a knotless pull-through technique. To review the functions of the labrum that we all know well by this point, the maintenance of fluid film, the action in joint stability, the action as a suction seal, and the role in load bearing all converge on this common goal, the way I think of it, as chondroprotective. And we learned about this for the meniscus in the knee some 30 years ago. We really only learned about it, maybe it's 40 years ago now in the knee. We really only learned about it in the hip in the last 15 to 20. We're a little behind the knee, but we're catching up and perhaps even surpassing. Now, in treating the labrum, one of the guiding principles that I've used in all the iterations of technique has been this simple statement from one of Reinhold Ganz's early papers, which said that the labrum sealing mechanisms are dependent on the fit of the labrum against the femoral head. So very simply, if the labrum is not fitting against the femoral head, it can't do any of those jobs. It can't seal the ball in the socket, it can't maintain a fluid film, it can't create a suction seal, and it can't bear load. It has to fit against the femoral head. And this was the biomechanical rationale that led me down this long journey of developing techniques to either repair or augment or reconstruct the labrum in a way that restored the contact of the labrum against the femoral head. And the first of those techniques was labral base refixation, which we published on back in 2010. These diagrams have now been seen in a lot of people's presentations in a lot of different places in the world, and they originated from that paper in 2010 that we published on labral base refixation, and I'm very happy that they've inspired a lot of different iterations of technique, all with what I think is the common goal of reproducing this seal. So early on, we identified that some repairs didn't reproduce that seal. Sometimes the labrum was everted or bunched or for one reason or another, not in contact with the femoral head. As I've emphasized, if it's not in contact with the femoral head, it cannot create the seal. So the labral base refixation, here are 2 permutations of it. It aims to restore the triangular cross-sectional shape of the labrum, restore the transitional zone, restore the suction seal, and in its later iterations to perform a labral repair without detachment. In the early parts of the procedure 10, 12 years ago, we used to detach the labrum, perform the acetabuloplasty, and then do a labral refixation. That's why it was called labral refixation, because we were refixating it after detaching it. Later, we developed this technique for arthroscopic acetabuloplasty and labral refixation without labral detachment. And you see in this slide two views that were very critical to this technique. The first on the left is the bird's eye view, where the scope is actually outside the joint, looking back in. So we're looking at the capsular side of the labrum. And then the second on the right is what we call the upper deck view. This is where the tip of the scope is inserted between the capsule and the labrum. So you see labrum on in the left side of the picture and capsule in the right side of the picture. And this allows us to work with the burr on the acetabular rim right above the labrum, right down to the junction with the labrum and the chondrolabral junction. Labral-based refixation, I think, a very useful technique for some labra. The controlled tension anatomic technique was subsequently made possible by the development of certain technologies. Specifically, tensionable knotless anchors, which allowed us to control the tension, enabled us to perform a looped suture around a labrum that would not support a labral-based refixation, and still achieve a consistent seal of the labrum against the femoral head by using this inserter out selective tensioning of the repair sutures, repair stitches. By being able to control the tension, we can avoid everting the labrum. We can check to make sure that the labrum is in contact with the femoral head, and we can position it either inverting it or everting it to get the desired position of the labrum to recreate that seal. So I'll move on to labral reconstruction and talk a little bit about where it fits in, and then I'll wrap up with my overall algorithm for which to choose and when. But I should start by saying that labral reconstruction is a difficult, complicated technique. It is technically challenging. This is not for the occasional hip arthroscopist. This is for the very high volume hip arthroscopist. This was a consensus study on the indications and graft type and technique amongst high volume surgeons that we published in the Journal of Hip Preservation Surgery. And there was consensus amongst this group of surgeons that, firstly, this is a technically demanding surgery. Only 8% of these surgeons were cataloged as high volume reconstructionists, meaning they did more than 40 reconstructions a year. And these surgeons, this was a group of already very high volume hip arthroscopy surgeons. So even amongst high volume hip arthroscopy surgeons, 92% of them don't do a lot of reconstructions. That's important to remember. And everyone agreed that the results in low volume hands may not be as reproducible. Here's one of my colleagues who participated in this particular consensus study, seen here in Madrid during the International Society of Hip Arthroscopy. So there have been a few Canadians who have invaded the USA in the world of hip arthroscopy, and I'm one of them. I'm born and raised in Canada, but I did migrate south of the border and joined the ranks of the Americans doing hip arthroscopy. And as a dual citizen, I'd like to give you a tip on how to catch a Canadian if you find yourself in the US surrounded by Canadian hip arthroscopists. So moving on to the technique on labral reconstruction. This is the knotless pull-through technique, and the technique was developed to make a difficult procedure as easy as possible, as quick as possible, and as reproducible as possible. There are some very good hip arthroscopists who do a wonderful technique for labral reconstructions, but it takes 4 hours. And I think that there are some serious downsides to a 4-hour surgery in hip arthroscopy. So we aim to make this technique much more expeditious and at the same time, very, very reproducible. So the indications, first of all, for me today for labral reconstruction in the primary setting are segmental loss of the labrum or a calcified labrum. In those two settings, labral repair is not an option. So labral reconstruction becomes the only option if we're going to leave the patient with a functional labrum. In the revision setting, failed previous debridement or a failed previous repair are my general indications for labral reconstruction. You see at the top here two examples of non-viable labra, and at the bottom a reconstructed labrum. Now, we did a study some years ago comparing labral reconstruction to labral resection, because that was really the question that I wanted to answer. When we're treated with, when we're faced with a irreparable labrum because it's calcified or it's too shredded for a repair, can we just remove the labrum and leave the patient without that segment of labrum, or are they actually better off with a labral reconstruction? That's the question, right? The question is, for an irreparable labrum, are they better off with a resection or better off with a reconstruction? And what we found was a lot more conclusive than what I expected. We found very significantly superior results with labral reconstruction compared to segmental resection for irreparable labral tears in the hip. So if we're asking the question, why restore the labrum? Firstly, there's biomechanical evidence. The labrum is critical to the function of the hip. That's been well established by this point. There's clinical evidence that we get better results with labral restoration than with debridement in that study I just showed you. And never to be totally cast aside is common sense. A lot of what we do in orthopedic surgery is based on common sense in whole or in part. And I think we all believe that the hip was made with a labrum for a reason. So it probably makes sense for us to restore it. Now, the next question in labral reconstruction is whether to do a segmental reconstruction or a circumferential reconstruction. And you see a diagram showing segmental on the left and circumferential on the right. The answer to this question really comes down to another question, which is, what is viable labrum? Because if the labrum is not viable, then we probably should reconstruct it. On the left, you see an example of a shredded labrum that's irreparable. On the right, you see an example of a calcified labrum that is also irreparable. As we've learned more about this and inspected the labrum more closely, I think we've come to recognize that a lot of the labrum that we might have left behind or thought was good enough in the past may not have been so viable after all. And as a result, my threshold for what is viable labrum has become higher, and that has caused my labral reconstructions on the average to get larger and more extensive and veer toward bigger segments or toward circumferential reconstruction in more cases, because when I look at a yellow or discolored or somewhat shredded or degenerative labrum, I feel I can make a better labrum with a reconstruction. So that caused me to enlarge the segments that I reconstruct when I'm doing a reconstruction. So here's the technique. This was published in the Journal of Arthroscopy. So I'm not going to get into incredible detail about the technique, but I hope that the article will be useful to you if you're interested in it. And again, the purposes of it were to create a very reproducible technique. You see here in these diagrams and these pictures that all of the anchors on the left are placed all around the acetabular rim before the graft is introduced. So we place all the anchors. And then on the right side, you see the graft is introduced and it is pulled through the joint. That's why it's called the knotless pull-through technique, because it's pulled through the anterior portal and out the posterior lateral portal. So it goes right through the joint. We anchor it first at the most medial point at the attachment of the transverse acetabular ligament anteromedially here with this anchor, and then anchor it all the way around the rim with the pre-placed knotless anchors. One of the most important elements of the development of this technique was to eliminate the need for measuring the graft. So in earlier versions of the technique that I used, we used to use devices like the one pictured here to measure the defect, and then we would size the graft to fit the segmental defect. Now, the problem is if we were off at all in the measurement, it was potentially disastrous. If we were too short, then we wouldn't fill the entirety of the defect and we'd have a lack of contact between native labrum and the end of the graft. If we were too long, then we have excess graft and essentially wouldn't have the tension that it needed to support the hoop stresses that the labrum is intended to endure. So by eliminating the need for measurement, the knotless pull-through technique makes it so that we can get the length perfect every time. And the way that we do that is by pulling the graft through the joint without sizing it. So we've got a 30 centimeter graft coming through the joint. We reconstruct it all the way around the defect, and when we're done, then we amputate the excess graft so that it's perfectly sized every time and we never have to worry about measuring. That was really one of the major advances of this technique that helped make it more reproducible and quicker. And the other aspect is the knotless repair aspect, where we use pre-placed knotless anchors that are tensionable anchors, and then we can very quickly pass and cinch around the graft, working from anterior or all the way around to posterior. At the conclusion of the reconstruction, I always look for what I call the money shot, which is where we release traction and confirm the seal of the labral reconstruction against the femoral head. And you see that in the picture on the right, where we've done a femoroplasty, and you can see the labral graft sealing the femoral head in the socket, reproducing that all-important contact between the graft and the femoral head. Another question that has often been asked is what kind of healing occurs. So we've had the opportunity to have a handful of second look arthroscopies after a reconstruction, and I'm showing one of them here, which shows, firstly, the graft is fully incorporated at the chondrolabral junction. This is really interesting. There's a very exuberant healing capacity when we've done a good preparation of the acetabular rim. And also the anterior and posterior anastomoses between the graft and the native labrum are almost invisible here. It's very difficult to tell where graft ends and native labrum begins because it healed so well. And the way that we get that to happen is by overlapping the graft with the native labrum. And that overlap provides the essential contact. The rim preparation provides the biology. You combine contact and biology and you get healing. So you can see that healing here. Durability of this procedure is an important question as well. We've looked at the minimum 5-year outcomes of arthroscopic reconstruction, and we've compared them to a benchmark labral repair group because we wanted to see if the 2-year improvements were durable at minimum 5 years. And you can see in the patient-reported outcome graph on the left that we did achieve favorable improvement in the functional scores at 2 years, and that those improvements were sustained at 5-year outcome, both for labral repair and for reconstruction for both groups. But here are some examples of the reconstructed labra. You see on the left 2 images incompetent labra, and on the right 2 images the anterior part and the posterior part of the labral reconstruction. So we're very pleased to see that for the irreparable labrum, even at minimum 5-year outcome, reconstruction was able to achieve functional outcomes that were comparable to a labral repair. But it's important to note that the patient satisfaction missed by a little bit. It wasn't quite as good in the reconstruction group as in the repair group. And for that reason, labral repair remains my gold standard. So there have been some centers that have pushed toward doing a reconstruction in everyone, in every single patient, even if the labrum could be repaired. That is not our approach at the American Hip Institute. We do repair the labrum when it can be repaired, and we reconstruct it when it cannot be repaired. So let's walk through the algorithm, how to approach a labral tear and choose the right procedure. So firstly, is the labrum viable? If it is not viable, then we have to debride it. And if we debride it, in some cases, maybe we can do a selective labral debridement and preserve enough labrum to preserve a seal. But if there's not enough labrum to preserve a seal, then we go on to labral reconstruction. And I showed you the technique. If the labrum is viable, then I want to preserve the labrum, and I explained the reasons why. So to preserve the labrum, let's consider, are we trimming more than 2 millimeters of rim? If we are, then the labrum is going to be unstable in most cases, and we should go on to a labral refixation. If we're trimming less than 2 millimeters of rim, then we should ask ourselves, is the labrum stable or not? If it is stable, then we may be able to perform an acetabuloplasty without a labral repair in some cases. If it's not stable, then we're back to doing a labral refixation. So next question, what kind of labral refixation? If we're not trimming more than 5 millimeters of rim, so anywhere between 2 and 5 millimeters of rim, then the control tension anatomic labral repair without detachment can work very well. And if we are trimming more than 5 millimeters of rim, then typically we'll perform a labral takedown, an acetabuloplasty, and then labral-based refixation to achieve the consistent seal. So in summary, back to our toolbox, our tool belt. I hope that this talk has given you some tools that you might consider adding to your tool belt, including the anatomic labral repair with labral-based refixation and the controlled tension anatomic technique, labral reconstruction using the knotless pull-through technique. And whatever we do, let's remember that labral function depends on the seal against the femur, and anatomic repair or reconstruction can allow preservation of that labral function. Thank you very much, and greetings from Chicago to Santiago.